Hello and welcome to this Patient Empowerment Network program. I'm Andrew Schorr, your host today. I'm a leukemia patient myself. I'm broadcasting from Carlsbad, California, just north of San Diego. I want to thank you for being part of this program. I want to thank our partner, the LLS, the Leukemia and Lymphoma Society, for being such a help as we produce this program. And I want to thank the supporters through educational grants to the Patient Empowerment Network, and they are Astellas, Celgene Corporation, Novartis, Pfizer and Seattle Genetics. And of course, the editorial control for this program all rests with us. You're going to hear the importance as we kick off the first in a series of 2 programs on AML. In this one, the importance of getting the right test for you or a loved one so you can benefit from the latest approved treatments, of which there have been several, and also what's going on in clinical research that may line up with you or your loved one's specific situation. You're going to meet guests from around the country, but let's first start by going to Rochester, Minnesota. He's normally in Northern California near San Francisco, but I want you to meet Kuldip Ahluwalia, who is in fact an AML patient. Kuldip, welcome to the program.
Well, thank you, Andrew. Glad to be here.
So Kuldip, you've had quite a rough go, and you worked for many years in the healthcare technology field, so you're a pretty astute patient. But what happened in 2015? What began for you? How were you feeling where maybe it led to illness?
It actually started in 2014. So the only symptom I had was I used to walk a lot. I was really active in my life, in my career and all. I used to fly around a lot. I would travel about 300 days a year. Wow. So I was pretty active, walking a lot. And suddenly I realized at about 5 miles per day, I was really losing my strength, my ability and all. It got progressively worse to a point where I couldn't even go upstairs to the bathroom. So at that time I realized something had to be done. So I went to the hospital, got tested. I got back the initial report and the doctor was laughing at me saying that, we ran the normal panels and everything was normal. Blood sugar levels, triglycerides, everything else, he said your white blood cells, red blood cells, all look pretty good. And he said, you probably have something minor. We'll give you a few inhalers or something else and maybe you'll recover. About 2 weeks later, I started taking the inhalers and things got really worse. Went back, talked to the doctor and said, let's take a serious look at it. 3 days later, I was driving and get a phone call. I was driving on 101. I get a phone call. And the way the call started was sort of surprising. They sort of said, what are you doing? I said, I'm driving. They said, could you pull off the curb? I was a little surprised. I pulled off the curb. And then they sort of said, if you don't mind, stop driving and we'll send an ambulance to pick you up. Oh. And I said, what's wrong? They wouldn't tell me. So anyway, I negotiated my way and I sort of said, I'm perfectly fine. I'm capable of driving. Let me drive home and then come over to the clinic in the morning. So showed up in the morning and my GP, my physician, he had assembled a team over there by that time. So before I walked into the room, I knew there was something serious. They didn't quite want to tell me what was going on, but I'm pretty persuasive when I want to be. I talked to them. They sort of said, you have a rare leukemia, a condition. They weren't quite sure exactly what it is. That my platelets had virtually gone down to 0. We were down at 6,000 level. So they said, you're really at danger of a lot of different things. We have to do a biopsy right away. It was Thursday morning. On Friday, I ended up going to the hospital, getting a biopsy. And then the fun started. Right,
and that resulted first in a diagnosis of MDS, right?
No, so the first one was basically the platelets had dropped. We did not know exactly what.
Okay.
But the assumption was that it's going to be AML or MDS based on the blood markers, yeah.
Well, let me just skip ahead a little bit. So ultimately in 2015, then you had a transplant, a half haplo transplant. There was no donor. So they were trying to use cells from your son to put you in remission. Right?
Correct.
And that lasted for about how long?
So that lasted just over a year. So the actual transplant took place in April, and till May, June 2016, I was perfectly fine.
Okay, and then you had another transplant because you sort of crashed, and that was a pretty unusual double cord blood transplant. And I understand one of the donor cells, sample of one of the donors had hepatitis C, that they had to treat those cells for that.
Correct. So we had to sort of take some precautions, but one of the donors was from this country, the other one was from offshore. And then there were a few unknowns, so we had to sort of navigate through all of that.
But the point is, here you are, you survived that. And I understand you just got out of all your isolation and treatment and all that in March. And here we are in the late fall, and you're with us. How are you feeling now?
I'm feeling great. I used to be 200 pounds. I was down to 128. I'm up to about 150 pounds, but I'm feeling great. And I'm starting to resume an active life again.
Oh, good. And you've started a foundation, the NeuVisium Foundation, to help people with AML, I understand. So
thank you.
Genetic testing is the theme of this program, and we're going to meet our experts in just a second. So I imagine you had a whole bunch of testing, including genetic testing along the way.
Correct.
And what is your understanding of how the genetic testing can help?
I was sort of lucky because, as I mentioned, when I first got diagnosed, the indication and the physicians insisted that we go into chemotherapy right away. I asked them, we started doing the bone marrow biopsy. Why don't we wait to get the cytogenics and the testing results? That was a tug of war with the physicians at that time. They acquiesced. It took about 2 weeks to get all the results and all in. Because of that, we changed the treatments a little bit. So initially we started with Vidasa for MDS. We went through 2 cycles of that over 2 months. That didn't respond. Then we went into the standard AML treatment for chemotherapy, the standard induction therapy. But that also gave time for my doctor to get approval to get a bone marrow transplant. Mm-hmm. So everything sort of worked into place because of the genetic testing. But we were able to determine that I was a poor risk, and I would be better served by having a bone marrow transplant set up, approved by the insurance company, and also have Stanford, in this case, look for donors for me.
Right. What was the right treatment for you? Okay. Well, don't go away. We're going to meet our first of our experts now, and that is Lee Greenberger, who is the Chief Scientific Officer at our partner, the Leukemia Lymphoma Society, and he joins us from Westchester County, New York, and he's a vice president with the LLS as well. Lee, thank you so much for being with us.
Pleasure to be here.
And so, Lee, you have a lot of research underway that you help guide and make grants from the LLS for. AML is an important research area for the LLS, isn't it?
I'd say it's a major area of research. So we have about 230 active grants placed globally, and about 30% of them are focused on new therapies for AML and understanding the basis of the disease.
Okay, and understanding the basis, and that can vary, or the specific characteristics of AML can vary by patient, right? Related to genetics.
Yeah, so no question about it. First of all, what we have found is that AML is just not one disease. It's probably about 20 or 30 diseases. And beyond that, the way you classify AML used to be on looking at the cells and looking at the chromosomes. Now we know that there are many mutations in this disease, and that further subdivides the patient based on prognosis and ultimately therapies applied to the mutations that are observed. And this is happening right now. I should add that some of this work goes back 20 years with the advancement of being able to find the mutations and then looking at all the genes and doing it quickly and economically. This has taken many, many years. And then to develop the drugs that actually target those mutations also takes many years. So what we're seeing is sort of a convergence of understanding the molecular basis of a disease, and then ultimately we hope to apply therapies to those molecular defects.
Right, and that's starting to happen. There were a number of approvals of drugs in the spring of this year, 2017, and a lot of research underway. Well, let's meet somebody who's in the clinic, if you will, and that's Dr. Amit Verma, who joins us from Montefiore Medical Center in Bronx, New York, just down the road from where Dr. Greenberger is. Dr. Verma, welcome to the program.
Thank you, Andrew.
Dr. Verma, so you're the director of the MDS program in the division of Hemato-Oncology there at Montefiore, and here we have Kuldip, who had MDS. Just to understand, you have a lab as well as you see patients. Is this testing now to understand what version of AML a patient has critical really for them to get the right treatment?
Yes, Andrew, like Dr. Greenberger said, the knowledge of what mutations can cause MDS and AML has really transformed our field. Instead of just relying on, physical appearance of how the cells looked, how the bone marrow looked, and then we used to decide on which chemotherapy to give, how much to give. We now can use knowledge of what mutations are seen exactly for each patient. And for some of these mutations, we do have medicines that are supposed to act specifically for these exact mutations. So we have already started using some of these drugs. There have been 2 approved this year, which are approved only for specific mutations that are seen in MDS and AML.
Okay, and you're researching others as well, right?
Absolutely. So, the way this started was technology actually helped us a lot. We have thousands of genes in our body, and it was very tough, a few years back to sequence all of them for a particular patient. It used to take months and months and thousands of dollars. Now we can do whole genome sequencing in a matter of days at a fraction of the cost. And when they did these sequencing projects, they figured out that in MDS and AML, there were about 20, 30 genes that were mutated most of the times. So now these have been used to build platforms, by commercial companies and by academic hospitals, where as soon as we have a suspicion for MDS and AML, we send the sample for testing, we get the result back in about 5 to 7 days, and then we use it for approved medicines. But as you rightly mentioned, we also can use these mutations to guide patients into clinical trials for drugs that are still in clinical research, but are not yet FDA approved. From a basic lab research point of view, we are always trying to figure out how does a particular mutation lead to the causation of disease. And we do it using human cells. We use mouse models of leukemia. We use, all different kinds of models to test that. Let's say you discover a specific mutation that doesn't yet have a drug, but how can we use, the existing library of drugs to kill these cells, or, to study how this mutation uses other parts of the body to cause disease. So a lot of research has come about after the discovery of these mutations.
So Dr. Greenberger, just for our audience, people, I think the public says, oh, when you're talking about genetics, talking about do I have blue eyes or brown eyes or black hair or blonde hair or whatever. Could you just help us understand where we're talking about genes here, this whole idea of oncogenes or things that have sort of gone awry, how they're different?
Right. So like Dr. Verma said, there are a few number of genes that we know that are so-called drivers. And what these genes do is once they become changed, mutated, it's like picture a string of beads. And one bead on this string is changed. That will make this protein now behave aberrantly and actually drive tumor growth. So once you see that, that's sort of a red flag. So that's an oncogene, a driver. And we're trying to understand what are the driver genes. And these genes, when you see that, will tell you, well, this is a good prognosis or bad prognosis. Sometimes a mutation doesn't necessarily mean bad prognosis. It may mean, oh, that patient's going to respond. In other cases, it means no, that's a poor prognosis, and we're going to have to develop an alternative therapy, or certainly be on the lookout for an alternative therapy through a clinical trial. Beyond that, what we've discovered is that every patient's different, and there may not be one mutation in a protein, but there could be many mutations, and the mutations change over time. So just simply by giving the therapy, you've changed the disease. So what you started with and what you end up with are different, and we need to understand that to figure out how to tailor the therapies.
Okay, so Dr. Verma, if somebody comes to Montefiore and is referred to your clinic, you're going to do certain testing, both for them to get the right care and to benefit research for others as well. But Dr. Greenberger, I have a question for you, and that is, what does the LS tell the community of people who find themselves with AML as far as getting the testing? What should they be asking for?
Right. Well, what we are doing, in fact, we're sponsoring a trial, is basically when you come in and get the initial diagnosis, usually because you can look under the microscope and see the cells and there's something aberrant, is to make sure that you actually get the genetic testing. You could have a mutation that will help the physician figure out which is the appropriate drug to be on, and how to tailor the therapy. So you want, obviously, the physician's physical assessment. You want to look under the microscope. You want to do the genetic testing. And this information can be obtained. We've done it in our clinical trial running really within a week. You can get the information back to figure out what is the appropriate therapy.
Okay, so Dr. Verma, you have patients who come from probably far and wide who finally get to you because you're a subspecialist. What, maybe people didn't get that testing somewhere else, but we have people everywhere watching. What would you say? First of all, it's important to get to a specialist today based on the research that's moving forward. And what would you say to them about getting the testing?
So I think in today's age, it's very important and critical for every patient with MDS and AML to get this gene mutation testing done. Usually in big academic centers, a lot of times the testing is done in-house, where our own lab looks for these gene mutations. But now we have commercial companies, vendors that do these tests, and your oncologist or hematologist who's seeing you basically has to send a tube of your blood to this company. And usually, if you have MDS and AML, your insurance should cover the cost of this test. So this is not that tough to do. Once they send the tube of blood, like Dr. Greenberger said, it takes about 5 to 7 days for your oncologist to get the result back. And then they can discuss the results with you. Some mutations are relatively straightforward. Some actually have drugs approved for them. And some, the significance is not entirely clear yet. Some mutations can actually be used to guide therapies by telling the patient, how high the risk is. For example, if you have MDS, a third of patients who get MDS transform to acute myeloid leukemia. So 2/3 of them do not transform to acute myeloid leukemia. And I think in terms of knowing what mutations you have, your hematologist or oncologist can determine what is the risk of you transforming to acute myeloid leukemia. And if you have AML, what risk group do you belong to? Do you belong to a relatively better subgroup, or do you belong to a higher risk group where maybe in addition to just chemotherapy, he may like to consolidate with a clinical trial or a transplant, for example. So it's not just drugs. The drugs, we still have relatively few of them for mutations, but the decision making, how to tailor make the treatment for you is more instructive when you have these mutations.
And Kuldip, that's exactly what you were pushing for, is you wanted the doctors to have the knowledge with you so that you could make decisions, right?
Correct. The challenge as a patient you run into is the institution you go to. Especially in the West Coast, everyone is with an HMO or PPO. And depending on the institution you end up in, they may have set protocols and set ways of doing it. So the question is, how do you get to the right physician who takes the interest in you to ask for those additional tests and then start the treatment?
So we're really talking about whether it's the patient themselves or a family advocate, really pushing for that to get to somebody like Dr. Verma, who specializes in this area, right?
Correct. And as I mentioned, in my case, when I ended up in the hospital, they did the biopsy. They wanted the treatment right away, start the induction therapy right away for AML. And I insisted that we'll wait a week, make sure we get the results and the cytogenetics, and then we start the treatment. Now, did we actually change the treatment? A little bit. But needless to say, we were much better prepared as to the risks that were involved. And number two, the backup plan, which was the bone marrow transplant for me.
Right. So Dr. Verma, it's kind of complicated nowadays. In other words, Dr. Greenberger was talking about all the different variations. So it's not just one cancer anymore, is it, Dr. Verma?
Yes, you're absolutely right. Physically, when you look under a microscope, a lot of leukemias can look similar to each other. But when you look under, their mutational landscape, you will figure out that it's not even, 5 or 6 different types. There are probably 20 types of AML with different sets of mutations, different combinations of mutations. Because you may not just have one mutation, you might have a combination of 2 or 3 mutations, which might change the way they behave and how your risk is.
Dr. Greenberger, I don't want to give people a lot of jargon, but just so they're kind of familiar with the territory, could you mention some of the names or numbers or whatever of some of the key mutations where a doctor may say to a patient, oh, we found this or we found that?
Right. So I'll give you 2 examples of which there are drugs. One is called FLT3, FLT3. And when that gene is mutated, we know that it can cause tumors to grow. We've done this in the lab. And we have a newly approved drug, that's midostaurin, to treat a FLT3 mutated patient. And I'll tell you a little bit more about that in a second. And then there's another one called IDH2. IDH2 is mutated in about 10-15% of patients with AML. And there's a newly approved drug, ednasidenib, to treat IDH2 mutant patients. Okay, so let's say you've got these mutations, right? And let's say you waited the 7 days to get the results back. The question is, what road do you proceed down? Do you proceed down with saying, okay, we're going to use this new drug and we're going to treat a newly diagnosed patient with it? Or are we going to just go to the conventional cytotoxic therapy and then maybe followed up by an IDH2 mutation? And so that's where these physician choice becomes so important in terms of evaluating the patient holistically. How is the patient doing? What do the cells look like? What are the mutational status? You could even imagine a mutation may be detected, but it's only in 10% of the cells. Do you treat with an IDH2 mutation inhibitor or not? That's some of the examples, and I'm sure Dr. Verma can amplify on that.
Yeah, why don't you, Dr. Verma? So give us some of the thinking you're doing based on certain genes.
Sure. So these 2 genes, which Dr. Greenberger mentioned, are very important because we have medicines for them. So FLT3, if you have a mutation, we now have an approved drug which actually can be given as part of the initial treatment, the initial chemotherapy that's given for AML or leukemia can include this particular medicine called midostaurin. And this was approved by the FDA after a big clinical trial was done, which showed that if you add this particular medicine to chemotherapy, it improves the rates of success and survival in patients who have this FLT3 mutation. Now, the other mutation, IDH2, is approved by the FDA, but right now it's approved for patients who usually fail or relapse after chemotherapy. This is an oral medicine, as similar to midostaurin, which was an oral medicine. And my personal belief from research as well as reading research that other people have done is that if possible, these new targeted therapies should be used as early as possible. What happens is if you give traditional chemotherapy and the disease comes back, the disease relapses, a lot of times the disease can turn out to be a little bit worse than when it initially had presented. And that usually happens because chemotherapy basically works by damaging your DNA. So it kills DNA. The cells that are dividing really rapidly, like cancer cells, get hit by this chemotherapy and die. But some normal cells also get affected by this, as we know. But what happens is if there are pools of cancer cells or cancer stem cells that survive, so they have been exposed to the chemotherapy and then they come back. They can come back with more mutations or with worse mutations. And then it gets a little bit tougher to bring them in control. So in the best case scenario, we find the mutations and we have a drug where, right now we have 2, but we still don't have that many. But it is our sincere hope that with the amount of research and, stuff that's happening in this field, especially with LLS's support and support of other organizations, we will have more of these drugs. So when we have more of these drugs, we would like them to be given right away if possible, because that would be our best chance of a cure. And, we all strive for a cure. We don't want control.
Amen to that. I want to remind our audience, if you have a question for you or a loved one, just send it in now to aml@patientpower.info. That's aml@patientpower.info. So Dr. Greenberger, first of all, I want to thank the LLS, and you help guide these decisions on the grants you make for research to people like Dr. Verma to move this forward to benefit patients today and tomorrow. I have a question about testing. So Dr. Verma was just talking about trying to give the right treatment right off the bat. But
right.
Cancer changes. So for the patient or family member now listening, does this argue, if you're lucky enough to be surviving for a while treated with AML,
right,
you should be retested?
Right. So absolutely, because this particular disease can change rapidly over a period of months. After you're done with your therapy, you really need to be analyzed. And we have grants that people that we're funding in the US to look at how these changes occur over time, to basically follow the patient over many months by repeated bone marrow biopsies to ask genetically, how are these cells changing? And as Dr. Verma said, after the therapy is done, you could have a different disease. And so now the treatment might have to be changed again. I'd also like to add one more important comment, and that is why do we think these genetically designed therapies are even going to work? And so I think Dr. Verma suggested they work. They typically work a little bit better than the chemotherapy, the cytotoxic therapy we've been using for 30, 40 years. And for some patients, they may work very well, but on average, they're a little bit better. We have seen in other leukemias that there are certain medications that basically can control the disease long-term, basically just keep a lid on it for 10, 20 years. We've seen this with some patients may know of Gleevec to treat chronic myelogenous leukemia, and that basically just can totally keep that disease under control for a decade. And we've seen it with ibrutinib. Any CLL patient might be on this oral medication.
With CLL.
We take this pill, and basically it'll keep CLL under control for many, many years. We don't even know how long, but it can be highly effective. So because of that experience, we think that can also apply to AML. But AML is more tricky because AML can change over time. It's very clear that this so-called heterogeneity or diverse mutations, it's like whack-a-mole. You'd knock down one, and then the next one comes up. And so you have to be able to follow the disease over time by repeated sampling to really, we think, the optimal therapy of having the drugs on the shelf, knowing what combinations to use, and possibly changing the therapy during the course of treating the disease.
So Kuldip, you've been living with it. As we talk about testing and retesting and having targeted therapy up front, if that's right for you, what would you say to people listening? Because you've had to think about it for yourself, but also there are other people now, and you meet some others dealing with AML. What do you want to say to them related to this area of testing?
Number one, form a team with the physician group. One of the things I've noticed, with myself and other patients, there are a lot of patients who come in, they're thankful to be treated by the physicians. They never have a dialogue, they never have a program, and they pretty much follow the regimen that's given out to them. I took the approach of forming a really good bond with my physicians. It sort of helped me have a continuous conversation with them, have a dialogue, like initially when I went into remission the first time, as to the program on how we're going to monitor it and how, when things go awry, how to get retested very quickly. So even now, as I mentioned, my transplant was in November. We have sort of come up with the program. Every 2 months I get tested, I get a bone marrow sample. Despite the fact that the insurance companies had a different program for us, we sort of kept the program so that we're tested, monitored, and reevaluated very, very quickly. So the relationship with the physician is really critical. And then having a team approach. And number two, a lot of physicians, they're treating a wide range of leukemias, wide range of diseases. They may not be experts on AML, especially when you get down to smaller institutions. So over there, my request, at least to my physician, was up front, was make sure that when I come in over here, you know who the experts are, who are on top of the latest literature, because one of the things that can happen is once you find some abnormality in me that you haven't sort of seen, you should know who to go to very quickly. And in my case, I'll be the first one to tell you that in both my physicians, initially at Kaiser and at Stanford, the physicians went out of the way to sort of say, okay, we've seen something which we aren't used to, let's call someone else. But I know in other situations where a physician didn't do that, they ended up with standard treatments. And right. I think that they would have been served better.
Right. So Dr. Greenberger, AML is a moving target now, right? I mean, you've both you and Dr. Verma have mentioned about drug approvals, new names we're starting to hear, and others that are in the lab. So it would seem like have some consultation or having your local doctor consult with a Dr. Verma, for instance, that maybe is really important because this target is changing all the time, right?
Right. So that and the research is improving. I'd say it's improving much faster now than it was 10 years ago. We have experimental drugs that patients could go on clinical trials, and which mutation you have and what drugs are available and what the performance of those drugs are in the clinical trials, as Kuldip has mentioned. Knowing people and physicians who are working in those trials to know what are the most promising drugs out there to get, if you needed to get on those clinical trials and hopefully get better results.
So Dr. Verma, let's talk about that. So if research is proceeding and some later stage research that you may be involved in as well, and then you have some newly approved drugs, part of the discussion with the patient who comes to you is, based on your tests, here's what I have that's approved, here's what I have in research, let's see how that matches up, including the research protocols with your situation, and make a decision together. In other words, the clinical trial discussion may be part of the initial discussion, right?
Yes, absolutely. So, the fact that we are doing the mutations is for a reason. We want to use that information to guide decisions that are tailor-made for each individual case. I give you some examples. There is this gene called P53, and this is mutated in about I would say 10, sometimes 15% of patients with acute myeloid leukemia. And when this gene is mutated, the effectiveness of traditional chemotherapy goes down. And there has been emerging data from clinical trials that agents like azacitidine and decitabine may be more effective when you have a mutation in the p53 gene. So for example, a patient comes with acute myeloid leukemia and the patient is elderly and has a p53 gene mutation. We might not elect to use the conventional chemotherapy for that particular case. And we usually see if there is a clinical trial for which the patient qualifies, which will provide them with either azacitidine or decitabine alone or in combination with another agent, which has shown exciting preclinical, meaning in the lab data or in small early phase clinical trials. And we would like to maybe treat the patient with that particular therapy rather than just cookie cutter conventional chemotherapy. So we, look not just at the mutations, and we look at, the overall performance status, how well the patient is doing, have they had any other chemotherapies for other cancers in the past, have they, do they have other organ system issues? So you take a holistic view of the patient, you combine it with the mutational data, and then decide. Another important consideration is, especially patients with AML, if they have any younger or siblings that can be potentially tested for matches for a possible bone marrow transplant. Because if you have certain high-risk mutations and the chances of relapse are higher after therapy, you preemptively want to plan to do an allogeneic bone marrow transplant after the patient goes into remission, because the thinking is that there may be the chances of a relapse after some time. So as soon as you have the patient in remission, if we are lucky enough to get a good match, it could be a related match or an unrelated match, we would then like to proceed with a transplant. So there are a few decisions to be made, and genetic testing helps in all of them.
Right. I should just mention I'm living with 2 blood cancers, chronic lymphocytic leukemia, and then later I developed myelofibrosis. Now in the case, and I'm doing well with myelofibrosis, but I have been typed for a transplant because myelofibrosis, like MDS, is one of those conditions that some percentage of people will develop AML. And I'm very aware of that, and my friends with MF are. So we think about that. So it's to have a plan, if you will, what you were talking about. So Kuldip, you didn't have a match, but they were able to manipulate the cells of your son for some benefit for some while in this half haplo transplant. So would you echo what Dr. Verma was just saying about getting information to have a plan?
Oh, definitely. So as I mentioned, in 2014, we started the treatment regimen. So at that time, we went to look for a match. I've got 2 siblings. Both of them were not a match for me. So we ended up looking at all the banks over here. In the US, we couldn't find a match. We couldn't find a match in Europe, anywhere else in the world. So at that time, we ended up doing a half haplo. My treatment was complicated by a little fun side sequence. After the induction therapy, my bone marrow did not respond. So I was an inpatient in the hospital for a long time. I was neutropenic, and they finally decided that after a lot of complications, a lot of visits to ER, that I'm not going to make it inside the hospital, send me in for a bone marrow transplant anyway. So anyway, we ended up going over there, used my son as a half haplo. They told me it's going to be a limited time before there will be a relapse. And at that time, we had sort of given anywhere from 6 months to about a year and a half for a relapse. It happened at about 1 year and 4 months. And again, this time we went with a double cord. But again, at Stanford, we had started looking for a match right away for cord bloods. And again, we went through an extensive search in all the data, all the blood banks over here, and we finally found one cord over here in this country and one outside the country.
Okay, so having a plan, though, is critical, and the transplant may be part of it. Dr. Greenberger, so I'm sure you would echo that. And also, I wanted to ask about trials. If you are helping fund research, and people like Dr. Verma are doing it around the country or around the world, it would seem like not only should the patient or the family member who's their advocate asking about getting the right testing, but also inquiring about trials.
No question about it. Particularly, so look, the response rate, if you're under 60 and can tolerate the intensive chemotherapy, you have about a 50% chance of having a good response. Once you're over 60, people either cannot tolerate the intensive cytotoxic therapy and have to go on to alternative therapies. And so, and the average age of AML patient is somewhere in the 60s. In other words, a number of patients really can't go on to the intensive cytotoxic therapy. So knowing what other options there are critical. I know Dr. Verma mentioned azacitidine. These are drugs that work, but they don't work nearly as well as the cytotoxic therapy, if you could tolerate it. And then you have to consider a transplant. So you really have to map out a plan. I wanted to add, in terms of the genetic therapy, one thing that LLS did about a year ago is, so imagine this. What would happen if there was a number of drugs on the shelf, let's say 10, and you walk in and say, okay, you have mutation in drug 2, so you should take drug number 2. You have a mutation number 8, take drug number 8. Oh, you have mutation in both, take 2 and 8. Imagine if some scenario like that were to happen, and that's basically what we've done. LLS has set up a so-called master trial where patients will get genetically tested and based on the mutation, be matched to an experimental drug. Remember, this is a clinical trial experimental drug that we think might work. And beyond that, we're moving towards going to combination therapy because we sort of suspect that combination therapy with targeted agents, these so-called that hit the mutation, are going to be very important. So if you cannot tolerate the intensive chemotherapy, which can work well for some people, you really need to be considering a clinical trial, and you need to know what mutation you have, who has the trial ongoing, where is it happening, and really begin to map out a strategy like Kuldip did as to what are the alternatives.
In calling the LLS, you all have people on the phone who can guide people as far as trials, let's say, that you're supporting, right?
Right, so we have an information resource center that operates from 9 a.m. to 9 p.m. The phone number is on our website, who can assist you. We have our experts who know about these trials there's about 20 of them placed around the country, who can guide you, honestly guide you to the physicians who either to educate the physician or educate the patient, and also to guide you to the physicians who ultimately will really decide what is the best therapy.
Right. I want to mention again, if you have a question for you or a loved one, just email it into aml@patientpower.info, aml@patientpower.info. So I also want to mention the devotion that many of our organizations have, the LLS with the resource line, the Patient Empowerment Network, in really helping you and your loved one understand how important it is to speak out, because a lot of people are timid about it. And then there are areas that are unfamiliar. And I just want to ask Dr. Verma this question. So when we talk about clinical trials, you know, the old fear people have is that they're going to be sort of a lab subject, if you will, and that if they don't get the good stuff that you're researching, the treatment they'll get won't be won't be effective. So help us understand, if somebody's in a trial, and let's say, I think you call it 2 arms of a trial. Somebody's getting the experimental drug, somebody isn't, maybe in combination. How does that work so they feel protected no matter what? Dr. Verma.
That's a great question, Andrew. There are 2 types of trials. There are trials that are early stage, They are usually called phase 1 or phase 2. And then there are trials specifically like the one you mentioned, which are called phase 3 trials. Phase 3 trials have 2 arms. So a patient can go into either arm, and it's usually a decision which is made randomly. One of the arms is an experimental arm, and one of the arms is a standard arm, meaning that it's a therapy that's approved by the FDA and that's used in standard treatment of that particular disease. In the experimental arm also, we have, every time there's a trial that's written, it has to go through an exhaustive review process, multiple rounds of review, where physicians and scientists, make the determination that, number one, this is not something that will do harm to the patient, and number two, if this is scientifically and medically justified to be tested. So if a trial is being offered to a patient, that means it's already passed that review by other oncologists and doctors and as well as scientists. Number two, when you're being approached with a trial, usually it's in a situation where the standard treatment is not going to be curative. This is offered in a situation where your physician feels that just by going with what's approved, what's standard, you are not getting the best possible chance for a cure. And in that situation, if you have any doubts as a patient, I would encourage patients to ask as many questions as possible. A good hematologist or oncologist will take time to answer your questions, no matter how many they are. And especially if it's a clinical trial, it is the job of the hematologist to tell you, slowly and with as many details as possible, what is the rationale, why they want to do this, what is the likely outcomes, and more importantly, what are all the side effects that can happen with that experimental agent. And the aim is not for the patient to feel like, they're just being used as an experiment. The intention here is to improve your care, to improve your chances of cure, and secondarily also acquire information which will help other patients down the road. Because unfortunately, these diseases are still not the ones that we can cure very well. And we are always looking to improve our cure rates. And, if we, let's say we treat a patient on a trial and it does really well, it will help get it approved for other patients. On the other hand, unfortunately, if the trial does not work, then we will know that this drug combination maybe doesn't do as well, and that will also help other patients. But that's a secondary objective. The first objective is to give the best possible chances for remission or cure to an individual patient. But it can be overwhelming. You're hit with this diagnosis. You suddenly start learning terms that you never heard of. There are many types of leukemias. Add, these 20 different types of mutations on top of it. Your mind freezes. And then you have somebody tell you that, look, we're going to treat you with an experimental therapy. That's icing on the cake. So I think the important thing is you take time, you talk it over with your friends and family, and then bring them also if they have questions. We frequently talk to patients' relatives on the phone. And I think it takes time. It's not an instant decision. No patient will ever make, instant decisions. Some do, but most don't. That will, put them in a reassured state of mind. So it takes time, and you should find a hematologist that sits patiently with you and answers your questions.
Thank you for that. I think that was a great explanation. Having been in a clinical trial for a chronic leukemia, I got a 17-year remission out of a new drug combination that was in a phase 2 trial. So and 10 years before that combination was approved. So I'm a big fan. We're starting to get in some questions, and we may go a few minutes longer if our producers say it's okay, just because we're getting them. Here's one that relates to time. Dr. Verma, I think this is right for you. This patient writes in, your presentation mentions the use of midostaurin with the FLT3 mutation, or enasiderin, if I can't say it right, with IDH2 mutations in induction therapy. You also mentioned that it can take 7 days to get the results back from the genetic test for these mutations. Most patients with de novo AML, as opposed to AML that came from AMS, cannot wait 7 days to start induction therapy. So the question is, what do you do while you're waiting for the genetic results?
So that's a very good question. There are some AMLs, where the patients present at very advanced stages of disease, where the leukemic cells are so high in number that the hematologist has to do something immediately. Now, in that situation where you don't have the luxury of time, the conventional approach is to start chemotherapy, to send the blood sample for testing. And both of these drugs, midostaurin as well as the IDH inhibitor, can be added on after you finish the 7 days of chemotherapy. So I do not think you lose anything if you are in that situation. And these drugs can immediately be added on as soon as you finish your cytotoxic chemotherapy. So I do not think that should be a particular problem.
Okay, here's another question that's maybe best for you, and that is there an approved drug or clinical trial for IDH1?
So right now, unfortunately, we do not have an FDA-approved medicine. There are many clinical trials that are testing IDH1 inhibitors. We have a trial open in our center, as do many other academic centers around the country. So if you have an IDH1 mutation, then you might be eligible to receive one of these new inhibitors, but it has not yet been approved by the FDA.
Okay, Dr. Greenberger, I have a question for you, and I want to get Kuldip's answer too, and this is a common question. I'm nervous about offending my doctor by asking for a second opinion. How can I get over this? Dr. Greenberger?
Well, I would say don't be shy. I mean, it's you who have the disease. You should be in control of this. I don't think any reasonable hematologist, oncologist is offended. In fact, it gives the patient confidence that the right decision is being made. So getting a second opinion is an important step. I recognize that with AML that it's sort of an emergency situation. There's still there are other physicians available who can help you, and LLS can steer you to getting a second opinion. So I think that that's a patient advocating for themselves, and most good hem-onc physicians will recognize that that is an important step to verify that it is the right decisions that are being made and the diagnosis is correct.
Kuldip, you'd endorse that, wouldn't you? Don't be shy.
Well, no, it's a given now. In this day and age, if you're not sure about the treatment regimen, you should get a second opinion, number one. But number two, the speed by which you can get the second opinion is much, much accelerated right now. So I totally agree. You should get one if you're not comfortable with the first prognosis and the decision.
Dr. Greenberger, we got in this question that often comes in along the way, and that is, did I do something to bring this on myself? Was there some injury or some situation I was in that caused AML? So I know you have scientists around the world trying to figure out what's going on with AML. Do we know where it comes from?
So the short answer is no. We really don't know what causes the disease. One thing that we have discovered is that there clearly is a correlation between age and having these mutations appear. So if you're 70, every one of us walking around who's 70, there's mutations in about 10% of those people. They don't have the disease, they just simply have the mutation. And we think what that is it sort of setting the stage for another mutation to occur where the disease will actually manifest itself. So there's nothing that we know that actually can cause the disease in terms of environmental exposure, with rare exceptions. Radiation therapy, other cytotoxic therapies can cause it. But for the most part, for an average person, we really don't understand. But clearly, the immune system and the blood system ages, as we all do, and it makes mistakes. And somehow these mistakes actually don't get corrected. And when a second change happens, you can actually get the disease. A rare event, but it can happen.
Okay, one more question. We're just going to go about 5 minutes over, and that is for you, Dr. Greenberger. If the genes get damaged and they start producing these tumor cells, can you heal a gene?
So that's sort of what I would tell you 10 years ago, that's Star Wars. I could tell you today that we were able to actually go into cells and correct a defect. So if there's a mutation in gene 1, we have the ability, at least in the lab, to go in there and correct it. And you can begin to envision a time where you say, well, you have this mutation, and what we're going to do is figure out, we're going to take your cells of origin that start with the disease, and we're going to go in and correct that. So an example would be in some families that have a higher chance of developing AML because they have a mutation that just is carried in their family. Some of the thinking is, gee, maybe we can actually go in and correct that defect and then replace that cell with a corrected cell and avoid the disease in the first place. But it's coming, and the technology is there to make it happen in the lab, and we're hopeful that that will actually be something that we might be able to use in the future.
That's hopeful. So, Dr. Verma, your big one of your big meetings of the year is coming up in December, the American Society of Hematology. Do you expect that this year there'll be a lot of discussion of AML to give patients hope and to have more physicians sort of understand the changing landscape and what's going on?
Absolutely. You know, AML is a big part of the annual meeting, and there are numerous really good researchers, both lab and clinical researchers, who are actively working on this. And we all send our latest, research findings to the meeting, and it gives us a chance to talk with each other and discuss and critique each other's findings. So, AML is in the middle of an exciting, area of research right now, and it will be featured prominently in the meeting for sure.
Right. Well, I want to just mention on our Patient Power site, there is an AML Center, and we have recent interviews with Dr. Olga Frankfurt from Northwestern and Michael Deininger from the Huntsman Cancer Institute, colleagues, peers of yours, Dr. Verma, explaining that. And we will be doing the second in our series of programs, probably right about that time, from ASH, if we can, where we will discuss the various drugs that have been coming out, the changes, and how you can take this genetic testing information and act on it with your doctor. And of course, the LLS as the resource center, and then the Patient Empowerment Network, who's helped support this program, has other resources for you. Dr. Greenberger, I wanted to get a final comment from you, what you'd say to families dealing with AML now, and to really reinforce the importance of getting the right testing.
So getting the right testing is essential. I think in this day and age that it would be the expected result for anybody who has this disease to really get it, so the physician and the patient can make an educated decision. I should also add that new drugs are coming. We've seen a couple of approvals. We sort of expect that there will be more approvals in the future directed towards mutations. And finally, I just want to add something we didn't cover, immunotherapies. There are new immunotherapies that are coming that have certainly been effective in other leukemias, and we expect that those are going to be also applied to AML and MDS as well, and these are coming. So I think it's just a matter of time before these therapies actually get approved and show their effectiveness either alone or in combination with other therapies.
Right, and we're going to tackle that in our next program. We're going to specifically talk about approved and experimental treatments, and that includes things that can switch on your immune system to fight the cancer that it may be didn't see developing the first time around. I want to thank you for being with us, Dr. Lee Greenberger, who's the Chief Scientific Officer of the Leukemia and Lymphoma Society, and we'll have you back. And thank you for all the work that you're helping lead and the LLS is helping fund. Thank you for being with us.
Thank you so much.
Dr. Verma, so you're in the trenches in the lab doing research and you're seeing patients. Just maybe hopefully we can end on a hopeful note. Are you encouraged for families and individuals touched by AML today?
100%. There's a lot of exciting scientific knowledge that we have about this disease that we didn't have just a few years ago. You know, there are already 2 drugs approved. There are many more in the pipeline. There, I would say, hundreds of clinical trials being done right now. And it's an exciting time for AML research, mostly because, you know, we see that this disease can be beaten with the right approach. Now we actually have the tools, we have the knowledge, and it's just a matter of finding the right treatment for the right mutation. And for the mutations where we don't have the right drugs right now, you know, I think in a few more years, we should have a lot more to offer. We are very, very hopeful.
Well, thank you. And we wish you, both you and Dr. Greenberger, you know, great strength and speed as you work on this. Dr. Amit Verma from Montefiore Medical Center in Bronx, New York, thank you for being with us.
Thank you.
And last to you, Kuldip, I want to say, so you've been living with it. So how do you view the future and in the context of this changing story related to treatment and research?
Number one, I'm encouraged by the amount of research that's being done and also the physicians educating themselves. From a patient perspective, the world looks a little different. In terms of the scientific research, the advancements that are being made on a scientific side is enormous. I think so. You know, we've talked about some of the changes, some of the things that are coming very quickly. The adoption by the medical community, the clinicians, is a lot slower, but it's happening. The one challenge that we still have is from the patient side, the patient management. What happens once the treatment is given and then you're, you know, left discharged from the hospital and you have to manage yourself in the isolation and sort of report back to the hospital. So that's the one challenge we face as patients. But nevertheless, the amount of research that's being done, the collaborative atmosphere that's being created right now within the hematology community, between the bone marrow community, is wonderful and a great opportunity for us.
Well, an opportunity for you should you need it, but Kuldip, Ahluwalia, I want to wish you all the best with your continued health.
Well, thank you.
Okay. Well, as we wrap up, I just want to remind people we will be doing another program, as I mentioned in this series, and we're going to get a lot more into treatments and research choices that come out of these genetic tests that we hope that you or your loved one will have so they get what's right for them. And I also want to mention the ongoing resources, the Patient Empowerment Network site, powerfulpatients.org. Take a look at the AML Center on patientpower.info and pick up the phone and call the Leukemia and Lymphoma Society and talk directly with someone who can support you. Often they can match you up with somebody who can talk to you individually, maybe even in your own community. But you are not alone, and there's a changing story here in AML, and it starts with you and your doctor getting the right tests so you know what your specific AML situation is. Thank you for being with us. I'm sorry I went a little bit over, but I know this is prime information for people. For the Patient Empowerment Network, I'm Andrew Schorr, and also I want to thank our sponsors again and really appreciate so much that they were providing support for this program. And the other one, and again, they've been Astellas, Celgene Corporation, Novartis, Pfizer, and Seattle Genetics, all devoted to people with AML getting what's right for them. Thank you for being with us, and remember, knowledge can be the best medicine of all.